Hi everyone, this is John Mandrola from the Heart.org Medscape Cardiology, and I'm at the American Heart Association meeting in Philadelphia, and I'm so excited to present and have a conversation with two saviors of interventional cardiology. Primary author Christopher Rajkumar and senior author Rasha Al-Lamee, who are authors of the ORBITA-2 trial, which came out positive for PCI. So first of all, congratulations.
Thank you, John.
Thank you very much.
You've already done many interviews on this, but before we get into some of the specific things that have been going on, talking online, just give us the basic rundown of what you did and what you found.
Sure. So ORBITA-2 was a placebo-controlled trial of percutaneous coronary intervention for stable angina, just like the first ORBITA trial. And essentially, the key differences in ORBITA-2 compared to ORBITA-1 are that we intentionally diverged from clinical guidelines in ORBITA-2. And I'm sure that will be the focus of some of the questions today, in that we wanted to test the unattenuated efficacy of PCI for angina relief. And the only way we could do that is by taking patients off their anti-anginal medications. There were some other differences in the trial as well. We incorporated patients with single and multi-vessel disease, and evidence of ischemia and evidence of symptoms were both mandatory prior to randomization. Patients were followed up for longer, 12 weeks instead of 6, and the big difference is also that we used a novel clinical endpoint called the angina symptom score, which encompassed daily reporting of angina from our patients, how much anti-anginal restarts they needed, and any adverse clinical events like acute coronary syndromes and death.
In ORBITA-1, it was a placebo-controlled trial of PCI as an add-on to anti-anginal drugs, but this was totally different in that they were symptomatic patients on anti-anginal drugs, and then a couple weeks before, you took them off the anti-anginal drugs to isolate the effect of PCI alone.
Exactly.
Correct.
Absolutely.
So, and then Rasha, tell us what happened.
Well, so what we found is that angioplasty, compared to a placebo procedure, improved that angina symptom score, and that patients had a far better health status on our angina symptom score. And in fact, that was collected every single day. And we saw that impact immediately, and it was sustained throughout that 12-week period. We also saw that patients in the PCI group were 3 times more likely to be free from angina and more likely to have an improvement in quality of life and an improvement in all of the various categories in terms of exercise time, treadmill, an improvement in CCS class, and also an improvement in the various domains of the SAC questionnaire.
Thank goodness.
Well, I know what it's like to be negative, so it was quite nice for it to be positive this time.
Right. The exercise time on the treadmill, which was the endpoint of ORBITA-1, was also positive by, what, 60 seconds. So is that a lot or is that a little?
Well, I mean, it equates to 1 full dose anti-anginal agent. So, you know, you're thinking about a procedure with costs and potential risk, and it's not negligible either, that cost or that risk, for 1 anti-anginal agent's worth of treadmill exercise time improvement. It's still, as a blinded effect size, far smaller than the unblinded effect size that we saw from the original ACME trial of 96 seconds, but of course it's far larger than what we saw in ORBITA, which was 16.6 seconds.
Right, but Chris, the slide you showed in the presentation of that gnarly LAD lesion, which no one would walk away from in my neighborhood, that's only equivalent to 1 anti-anginal tablet. It's hard to believe.
Of course. So I think one important point is that, of course, that's an average treatment effect.
Okay, fair enough.
And of course, we've got some huge responders in ORBITA-2, and we've got many patients who saw no response at all, and that is a whole other subject of further research.
Okay.
That's a watch this space moment, I think.
Your trial has obviously generated a lot of stuff online. One is the ethics. People ask, how is it even ethical to do this? So let's answer that.
I mean, I've been answering questions on ethics for a long time now, right? It's been about a decade where people have said that the trials that we're doing are potentially unethical. I'd say it's unethical to do procedures or to give treatments without knowing if they work. And what we wanted to do here was test whether angioplasty worked. And I think it's absolutely reasonable to do a placebo-controlled trial as long as the patients understand that they might potentially have a placebo procedure without any potential benefit, but there's an associated risk. Then I guess you're going to come to the ethics of taking them off their anti-anginals.
We want to talk about that, but I also want to emphasize your comments to my AFib ablation
Well-
community, which are seemingly afraid to do a proper sham control.
So look, it's time for these trials to become the entry standard, not the gold standard that we try and achieve at the best possible, research facilities. The entry standard for a new procedure that might purport to improve a subjective endpoint like quality of life, or an established procedure that has risk and cost. And I often say, if you're giving someone homeopathy and you don't think there's any risk associated to it, it doesn't really matter if all of the overall therapeutic effect is placebo. But if you're giving someone a treatment that might have risk and cost, then you need to understand what proportion of the overall therapeutic effect is placebo and what proportion is physical. And the only way you can work out that true physical effect is to do a placebo-controlled trial.
Thank you. Thank you. Okay, let's move on to the issue of taking people off their medicines, because there's been some conversation that this is like taking someone off their cancer chemotherapy.
Yeah.
Either one of you can address that.
Well, I'm happy to take that one on.
Okay, very good.
There are medications that are there for risk reduction or disease modification, and those medications in ORBITA-2 were continued. Everyone was on their aspirin and their statins, and if they were on low-dose statins, they were placed on high-dose statins. And as you know, after randomization, they all actually had dual antiplatelet therapy. But we felt that those anti-anginal agents were there for symptom relief, and they have no prognostic benefit. And ultimately what we were doing was akin to stopping someone's paracetamol when they're having headaches, or stopping their codidromol when they've got knee arthritis. We were not stopping their chemotherapy agents because they had cancer. Now, of course, if they were on an anti-anginal agent that had other properties, rate control for atrial fibrillation or heart failure, those continued, and they were counted as part of the angina symptom score. And importantly, and this was important to the ethics, if patients had symptoms that they deemed to be too much, they called the team and they had 24/7 access to us. And they were then able to be restarted on anti-anginals or up-titrated, and that was counted in the score.
Okay.
When we sat down with the results of ORBITA-1 and designed ORBITA-2, we did it with a patient focus group, and we asked them what they wanted to understand and what was important to them. And, I think many physicians will understand this. Lots of patients told us that for them, taking more tablets was worse than having a little bit more pain. And so that's why the trial was designed the way it was, with more anti-anginal medications scoring higher than higher frequencies of angina.
It's a scientifically great study. It shows pretty clearly that PCI has a placebo-resistant effect. But how does it apply clinically? I've heard some people say this doesn't answer a clinical question and shouldn't be used in the clinic. Either one of you, how do you feel about this?
We don't recruit 500 patients across 2 placebo-controlled trials just to sort of generate data. Of course, it's there to apply to clinical guidelines. Real-world evidence, which I showed yesterday, shows that actually the average patient having an elective cardiac catheterization is not on 3 doses of anti-anginal medications as in the first ORBITA trial. In fact, about half are either taking no anti-anginals at all or 1. As Rasha touched upon, is that many patients struggle to take high-dose anti-anginal medications for what is essentially an indefinite period of time. So we think this certainly it can be practice-changing and should be practice-changing, in that we should be able to have a more patient-centered approach here and offer patients more of a choice, because now we have an evidence base for that choice of an upfront anti-anginal procedure such as PCI or upfront anti-anginal medications.
It is also important for people to remember which patients were in this trial. They were patients who were symptomatic with angina, they had severe anatomical stenoses, and they had evidence of ischemia. So we wouldn't want is a throwaway message that now takes patients with wishy-washy symptoms and non-severe stenoses and no evidence of ischemia having angioplasty. People need to think about the criteria of the patients that were in this trial. They were pretty symptomatic with, as you saw, some of those angiograms, some pretty severe stenoses.
I think many patients would just say, fix it, and of course, doctors in our health system are incentivized to fix it, and so I can imagine that few patients would decide not to fix.
Yeah, so perhaps it does reflect different patients in different geographies. Our patients are quite up for that conversation, actually, and we do find there's certainly patients who don't want that risky procedure. I think what's also possible, we know this from courage and ischemia now, is to take your time. And actually, one of the things that the guidelines have told us is if you take multiple anti-anginal medications and it doesn't work, consider a procedure on top. ORBITA-1 showed us that the incremental benefit of angioplasty is very small. So we're probably sub-selecting a bunch of patients who have the least to gain. Perhaps actually the strategy, and I'm just going to put that out there, it's of course not tested, but maybe when you give your patient their anti-anginal and they start to feel better, perhaps that's the patient with cardiac pain. And maybe the conversation needs to be, are you happy to continue on this? Or do you want us to consider reducing your burden and fix your stenosis?
When I look at the graphs that you show for the anginal scores and for the angina class, patients who have PCI can still have residual pain, and patients who didn't have PCI can have resolution. So what's happening there?
One thing that we learned from this is that going back to the medical school textbooks, we learned how to take a history at medical school. We think we know how to diagnose angina, but actually the link between coronary stenosis, ischemia and angina is much less linear than we thought it was. Our trial wasn't designed to look into the cause of those residual symptoms, and it will be, I suspect, a mixture of, perhaps some patients with some microvascular disease, albeit the ischemia was reduced significantly, some patients with some non-cardiac symptoms, and of course some people who continue to have symptoms from their epicardial coronary arteries. PCI isn't perfect, and that's a clear
Excellent.
message.
Okay, so last question, what's next? Are you just going to take it easy and go do PCI?
Our team's restless. So we've already got a plan. I thought, as of yesterday, I had a plan for ORBITA-3. By the time we had dinner last night, we've now got a plan for ORBITA-4 as well. Okay. So we've got all sorts of ideas about what's next. This question about residual symptoms is clearly important, but also what everyone's going to see before we get to ORBITA-3 and ORBITA-4 is lots and lots of secondary analyses from the data we have in ORBITA-2, thinking about the predictors of response, because it's time we stop thinking about mean responses and considered which patient feels absolutely 100% the next day and which patient doesn't feel that. How can we predict that before we put in our stent? The other thing we're going to do a lot of is combining the data from ORBITA-1 and ORBITA-2 in a 501 patient level meta-analysis, where we'll be able to look at the introduction of anti-anginals and what they did, the consideration, of course, the endpoints, there's some endpoints that match up and others that don't, but in a combined data set, what can we understand from that data? And I think what's also just really important to consider is that when you've got your patient in the cath lab or in the clinic and you're considering whether to take them to the cath lab, many physicians will probably have an idea already of which patients might have benefit. So the bit of ORBITA-2 that we're really excited about is we did video diaries of lots and lots and lots of the patients telling us about their symptoms. And we're going to analyse whether just the description of symptoms, the way a patient tells us, is a predictor of response.
Like a qualitative study. It's really awesome.
I keep saying the videos are going to be the gold dust, because the videos are what we have in clinic, right? Them telling us their history, and how can we work out which ones we can fix?
Excellent. Thank you so much for coming in and settling some of these questions for us. I really appreciate it.
Thank you, John. It was a pleasure.